Good afternoon. I'm Marta Bills, Maternal and Child Health Director with March of Dimes, and along with my colleague Mashariki Kudumo, we want to welcome you here today for the first of two webinars focusing on improving perinatal health and advancing birth equity. November is Prematurity Awareness Month, and today is World Prematurity Day. So we know that many around the globe are gathering to learn and have conversations like this one. And that's a good thing. As we know, there is much work to be done. In fact, March of Dimes has just released our 2020 report card. And like most of what has come our way this year, the report card results are discouraging. For the fifth year in a row, the preterm birth rate has increased nationally as well as here in California, from 10.2% across the country to 9.0% here in California. In California, all racial and ethnic groups saw an increase in their rate, with the exception of white women who remained the same. At 12%, Black women experienced a preterm birth rate 43% higher than all other women in California. It's also worth noting that the greatest increase was among American Indian Alaska Native women, whose rate rose from 10.5 to 11.3%. Our Hispanic mothers were just under the state rate at 8.9%. Of the 100 US cities with the most births ranked by preterm birth rates, California is represented by Irvine, which is in second place, the second best preterm birth rate of 5.6%, and by San Bernardino in 61st place and a rate of 10.7%. Across the country, the worst city preterm birth rate wise is Detroit, with a staggering rate of 15.2%. And if thoughts about the why behind those data don't leap immediately to mind, then you will soon be enlightened by our wonderful panelists. So let's get started. I'd also like to acknowledge and thank Cedars-Sinai for supporting our webinar today. Our first speaker, Dr. Mariam Naqvi, is from Cedars-Sinai Medical Center, and she will be providing an update on COVID-19 and pregnancy. Following her presentation, Dr. Ravi Durjati from Stanford will discuss strategies to improve equity in NICU outcomes. And our last speaker will be Dr. Karen Scott from UCSF, sharing with us about advancing anti-racism praxis in perinatal population health equity research. We're going to hold questions till the end of the session, the last 10 minutes, but feel free to go ahead and enter them in the chat or the question box as they come to mind. We'll also be making a recording of this presentation available, so you don't need to take furious notes. Thanks so much for being here, and I'm going to turn it over to introduce a little bit more about Dr. Naqvi. She is an assistant professor in the Division of Maternal Fetal Medicine and Department of Obstetrics and Gynecology at Cedars-Sinai Medical Center, and she serves as the OB-GYN Clerkship Site Director for the David Geffen School of Medicine at UCLA. Dr. Naqvi completed her undergraduate education at UC Berkeley, after which she spent a year as a full-time researcher at UCSF. She completed medical school at UC Irvine, her OB-GYN residency at Stanford, and a maternal fetal medicine fellowship at Massachusetts General Harvard Medical School. Dr. Naqvi's research focus grew from an interest in asthma phenotypes among underrepresented communities. She's traveled to South Asia to participate in global health research and ultrasound dating with the World Health Organization. Her current clinical and research interests include multiple gestations, prenatal diagnosis, peri-viability, and healthcare disparities. And she has over 40 publications in peer-reviewed journals as a young investigator. Most recently, she's been intimately involved with the COVID response at Cedars-Sinai and has co-authored several publications on treatment and outcomes among pregnant patients during the pandemic. Thank you so much for being with us today, Dr. Naqvi.
Thank you so much for having me. Share my slides here.
Looks good, Dr. Naqvi.
So again, thank you so much for that lovely introduction. It's really an honor to be able to speak at this gathering. I'll be speaking about COVID-19 and pregnancy and just give a general update in terms of what we've learned about this over the last few months. I have no financial disclosures or conflicts of interest. And so here's a brief outline of what I'll be reviewing today. I'll go over some national and local case statistics for COVID-19, both in the overall population and in pregnancy. I'll review the demographics and disparities among affected patients. And then we'll focus on pregnant patients and talk about the disease manifestation in this group, specifically vertical transmission and impact on pregnancy outcomes. And then we'll end with talking about some of the management considerations specifically for pregnant patients and touch upon kind of the recent information that's come out about vaccines and their lack of inclusion, unfortunately, of pregnant patients. So we hit sort of an unfortunate milestone recently this week, which I'm sure all of you are aware of, where we hit in California 1 million coronavirus cases, and only the second state following Texas. And you know, if we look at kind of how the pandemic has gone on in California, of course, early on we were actually very lucky and did not have as many cases as our colleagues in the East Coast. And then over the summer we had sort of our first surge. Things were getting a little bit better, and then of course now we're on this steep part of the slope once again. And it's funny, I think I put this here a couple of days ago, where our daily new cases in California was in the 6,000 range, and as of this morning, according to Governor Newsom's tweet, we're actually closer now to 8,000 range. So daily new cases continue to rise really on a daily basis, and unfortunately Los Angeles carries a great burden of this rise in increased cases. If you look at LA County, total cases now are over 300,000. The deaths are approaching 7,000. The test positivity rate has actually stayed pretty stable at 5%. And if we look at this graph over here, this again shows the cumulative cases, which slowed down a little bit, now starting to rise again. The cumulative death rate slowly rising, but reassuredly the case fatality rate has actually pretty much been stable in the 2% range. So of the patients that are getting COVID-19, the rate of death seems to be overall stable, but we'll talk about some variations of that in a few moments. If you look at disparities in positive tests and disease severity, looking at the CDC data, we get some information in terms of some of the racial disparities that we see, although this doesn't totally show the whole picture. And I'm going to spend a little bit of time on this. The CDC is great because, of course, it has the largest numbers, but we don't have race and ethnicity data available for a huge part of the population. So here on the left, we have cases. On the right, we have deaths. For the cases, race and ethnicity data was only available for half the cases, and then for death data, it was available for about 80%. But even so, if we look at our proportions of different racial groups based on census data, a disproportionately high amount of Latinx patients and Black patients are getting affected with COVID-19, and certainly for Black patients are dying at a higher rate from COVID-19. Now, if you look at really just national data, it doesn't account for a lot of variation that we're seeing at the statewide level. And I think it's really the statewide and local level that we see a lot of this variation in morbidity from the disease. So for example, we take a state like Louisiana. In Louisiana, about 30% of the population is Black. 70% of COVID-19 related deaths in Louisiana are among Black patients. And we see similarly in Michigan. Michigan, about 14% of the population is Black. 40% of COVID-19 related deaths are among Black patients. And so when you look again at those national figures, you see a couple percentage points different. But when you look at different demographic areas in the United States, we can see that these disparities are quite severe. This again comes from CDC data, and this is not as up to date as that initial slide. This is coming from the summer, but on the two right columns here we have Black patients, and here we have Latinx patients. Black and Latino patients are hospitalized at almost a 5 times greater rate for COVID-19. And if you look at this column again, Black patients here, and this is American Indian or Alaskan Native, death is occurring in anywhere between 1.5 to 2 times higher rate in these populations. And again, these numbers are a lot more stark if you're looking at individual hospital data and statewide data. And so not surprisingly, we see the same issues among pregnant patients. And these are smaller studies. This is not national data, but I do think, again, the the kind of the smaller studies do capture these disparities a little bit more effectively. And so in the first study, these are both looking at kind of the initial surge that happened on the East Coast. The first study is looking at almost 1,600 patients in the Yale New Haven system. These are pregnant and postpartum patients between March and May of 2020. And in this group, Hispanic ethnicity was a risk factor for both COVID-19 and for having moderate to severe disease. In the second study, this was done by some of my old colleagues at MGH, also looked at Hispanic and non-Hispanic pregnant patients that were tested as part of the universal testing protocols for COVID-19 and Mass General. There, again, Hispanic pregnant patients represented 18% of the population, accounted for 60% of hospitalized patients for COVID-19. And then this is an interesting study because it's looking actually at seroprevalence. So we can argue a little bit about the accuracy of IgG and IgM antibodies for COVID-19, and antibodies do tend to be somewhat, I guess, flaky, for lack of a better term, for many infectious diseases. But even if we look at seroprevalence, and this was done in Philadelphia, overall, in almost 1,300 pregnant patients that were tested for antibodies, 6% had an IgG or IgM antibody for SARS-CoV-2, and that was a 10% seropositivity rate in Black women and a little over 10% seropositivity rate in Latinx women. Both of these percentages do reflect a higher proportion that would have been expected in their general population. So this could be related to different housing conditions, inability to socially distance, perhaps due to jobs, living in different kinds of communities where there's not enough spacing. There's a lot of possible reasons for this, but even just having the exposure to the disease seems to be higher in some of our minority populations. And so being a pregnant woman during this pandemic, it can really affect a patient in a lot of different ways, even if you're healthy. So, you know, there's so many other effects of the pandemic, even when you are not sick. Of course, appointments are happening less frequently. There's a lot of different variations now to inpatient and outpatient protocols in the hospital. People don't always have their support person available. That's changing a lot with labor and delivery, but certainly initially in the pandemic, patients didn't have a support person or had maybe one support person where that wasn't necessarily an ideal situation. And still in the outpatient clinics, patients are generally coming alone, and patients, of course, have different needs for support depending on where they're coming from, their literacy and of their medical complications. And so this really is impacting prenatal care. We know that there's higher rates of anxiety and depression in pregnancy right now during the pandemic, and this is also affecting minority populations disproportionately. And all of these, there's concern that are going to lead to a widening of the health disparities that we've already see in pregnancy morbidity and mortality. We still don't totally understand the impact on other pregnancy complications. Again, we're talking specifically about healthy patients in terms of fetal demise, preterm birth. There is data that's out there, but it's conflicting. There is some data that suggests that the stillbirth rate is going up. There's also data that suggests that it's not. But I don't think we're really going to have information about all of this until, well, hopefully when this pandemic is over soon, but probably not for several months. For the rest of this talk, I'm really going to actually focus on being pregnant with COVID-19. And so what are some of the considerations that we need to take in this specific patient population when they are affected? And so I'm going to go through this sort of in a QA format, because this is kind of how we are presented with these questions and from our patient population. And so to start, is severe and critical disease from COVID-19 more common in pregnant patients than a non-pregnant population? And so, of course, we do have answers to this now from the CDC data, but I kind of want to go back to earlier on in the pandemic. This was the first study that came out of New York City. And when this came out, you know, we really kind of felt almost like a false sense of reassurance that our proportions of mild, critical, and severe disease were pretty similar to what was reported initially from the data coming from China. At that point, about 86% in that initial pregnant cohort had mild disease, about 5% had critical disease, and about 9% had severe disease. And so when we do a side-by-side comparison of pregnant patients and non-pregnant patients, this wasn't so different. But what we really do kind of a deeper dive in who these patients are. This bar graph here on the right, this is actually showing the age distribution in our pregnant patients from New York. Shows a mean age of basically 30. And then the age distribution of those initial studies that came out of China with obviously a much older age. And so really, I think we have to ask ourselves, is this what we would expect? I mean, patients who are pregnant are generally young of reproductive age. Is it actually expected that we should see the same rates of mild, critical, and severe disease? I think we should probably see less severe and critical disease in a younger and healthier population. So even though those percentages at face value seem really, really similar, I think early on there were clues that clearly our pregnant patients were at least somewhat of a higher risk. And then the CDC came out with sort of 2 installments of data, first in the summer and then most recently actually earlier in November. And so I'll go through that here in a little bit more detail. But certainly pregnant patients were found to be at increased risk for having more severe disease. And so I'm going to go through this in a stepwise fashion only because I do think it highlights both the kind of strengths and limitations of this data from the CDC. They started with about 1.3 million patients that were of reproductive age, and then actually excluded over 800,000 patients because there was no info about their pregnancy status. So really, we're only studying 35 to 36% of this population that we knew pregnancy status in, of which closer to 400,000 were symptomatic. And so it's important to know that this data is applying to symptomatic patients with COVID-19. This is not necessarily applicable to patients who are testing positive as a part of a universal testing protocol on labor and delivery and don't have symptoms of COVID-19. So of these patients, about 6% were pregnant, which comprised about 23,000 women, and 386,000 patients were not pregnant, and again, both groups with symptoms of COVID-19. And to give a little bit of that racial ethnic breakup of the pregnant population, again, 25% were missing race information, so this is why these numbers aren't really adding up, but 24% were white, about 14.5% were Black, 30% were Hispanic, and 2.4% were Asian. And this does not reflect the sort of racial ethnic breakdown of birth data from even 2019, when about 50% of women who were delivering were white and about 24% were Hispanic. So even here with a lot of limited data, we can see that these numbers are not reflecting our population in the way that we should expect. And so when we compare pregnant women and not pregnant women, so there's a lot of data on this slide, but I do think that this is really, really crucial in terms of how we counsel patients. Most helpful is probably this chart right over here, which showed that 10% of women who were pregnant did end up admitted to the ICU, about 3% who required intubation, 0.7% required ECMO, and then there is a 1.5% risk of death in this population. And then that's compared to these percentages in the not pregnant population. If you look all the way over here, these are the adjusted risk ratios. And if you really, even if you look just at the adjusted risk ratio for death, which is 1.7, that's a 70% increase in death from COVID-19 in pregnant patients as compared to non-pregnant patients, which is of course a terrifying number if you hear it that way. I have found that counseling patients, these numbers over here tend to actually be the most helpful because it shows that even though, yes, the risk is increased in the pregnant population, the absolute risk is still overall quite low. So for example, for death, there's a risk of 1.5 deaths in 1,000. In non-pregnant, it's 1.2 per 1,000. So yes, there is an increase, but the absolute likelihood of these terrible events occurring are still, thank goodness, not very, very high. I think the most dramatic is probably the ICU admissions, where it's about 10.5 per 1,000, 3.9 per 1,000 for non-pregnant patients. But a lot of this may also be related to having kind of a lower threshold to send patients to the ICU or hospitalized pregnant patients, and just because of our sort of increased level of concern, and then also our lower goals, or I should say higher goals in terms of oxygen saturation. And then coming back to outcomes for Black patients, and again, this is, I think, really, really important to just keep coming back to from the CDC data. They had a total of 57,572 patients in this group. So it was Black women aged 35 to 44, pregnant and non-pregnant. They comprised 14.1% of the entire study population and were 37 almost percent of the total deaths from COVID-19 in this age of reproductively aged women. So, I mean, even with the sheer amount of missing data that the CDC has on race information in this patient population, I mean, this is just a complete travesty, and unfortunately consistent with what we've seen in terms of racial disparities for other medical conditions and indeed pregnancy. And so the key takeaway points from this recent update, again, that was published, I think, November 6th, so earlier this month, is that there is indeed an increased risk of ICU admission, invasive ventilation, and death in pregnant patients compared to non-pregnant patients, but important to counsel our patients that these absolute risks are still low, and there are indeed worse outcomes for Black and Hispanic women with COVID-19, actually regardless of pregnancy status, but certainly within the pregnant cohort. And so what is the typical disease progression in pregnant women with severe COVID-19? It's actually pretty similar to the non-pregnant population, maybe shifted a little bit earlier. And so this is one of the earliest studies that came out. I still think it's one of the best studies, so I still cite it. And when I speak about COVID, but this included 4 sites of 64 patients total that all had severe or critical disease. Typically, patients are hospitalized at day 5 to 6 of symptoms and then require oxygen around day 7 to 8. They found that typically patients are spending about 2 days in the hospital before they sort of decompensate if they're going to go in that direction. And so that first 48 hours of admission is really, really crucial when we're considering treatment options and interventions that may possibly help for this population. Of course, we know that data in pregnancy is unfortunately not so abundant. And then our pregnant patients with COVID-19 have increased risk for obstetrical complications like preterm birth. And so this is what our patients are very concerned about when they're affected with COVID. The CDC data, again, a bird's eye view, it's always a little bit tough because there is missing information, but they found that looking at neonates born to moms with confirmed SARS-CoV-2, that there's about a 13%, 12.9% rate of preterm birth. That's compared to a 10.2% baseline rate overall of preterm birth. Of course, with this data, there's no real adjustment for risk factors of preterm birth. There's a lot of missing data. So what that true overall rate of preterm birth is nationally from COVID-19, we know that it's likely to be increased, but we're not really sure what that number exactly is. And then this is also a little bit more contemporary. This is a meta-analysis that included 77 studies, of which 35 just focused on perinatal outcome. They found a slightly higher risk of preterm birth, around 17%, and a 6% risk of spontaneous preterm birth. And so we'll talk about why that's a little bit important here in a moment. But actually no differences in other perinatal outcomes, including C-sections. And so if you look at the individual studies, most actually have really high C-section rates in women with COVID-19 when there's no comparison group. And when they actually included studies in the meta-analysis with a comparison group, C-section rates weren't as statistically different. And so this is, again, going back to that initial study by Pierce-Williams, which is still my favorite study on pregnancy outcomes, because they really were very detailed in terms of why patients were getting delivered when they were getting delivered with severe disease. And so, of course, the initial data that came from China and from the United States showed a really high risk of preterm birth and cesarean delivery with almost a 60% rate of preterm birth in this population, albeit these numbers were quite small, and then a 75% rate of cesarean delivery in this group. I think what's interesting about this study is that the majority of these patients, when they were delivered early, were delivered because of worsening maternal status. And actually only 6% were delivered because of spontaneous preterm labor. So I think that we do have to keep in mind that when we do talk about preterm birth in this population, especially in women who do have severe COVID-19, it tends to be because there is a decision made by the providing team that delivery may improve either maternal status most of the time or fetal status, which can definitely be affected if the maternal status is declining. And so most of this preterm birth does tend to be iatrogenic. Same with cesarean delivery. I mean, the C-section rate, you can imagine in someone who is a severely compromised from a respiratory standpoint is probably not going to be able to labor. There actually have been case reports of patients who are intubated and able to still have a vaginal delivery, but that's usually the more challenging route to go for various reasons. And so key points are that severe and critical disease are associated with a higher C-section rate and preterm birth, although the exact amount or strength of that association is still unclear. Mild and asymptomatic disease is probably less likely to be associated with adverse pregnancy outcomes, but that data is still incomplete, and so we'll have to know more about that hopefully next coming months to years. There have been case reports of fetal growth restriction and fetal loss with COVID-19, but they're case reports, and these are, especially with fetal loss, it is a really rare event, and so we don't totally understand that relationship, but certainly in the outpatient setting for women who have had COVID-19, we are really closely monitoring for that. Is there evidence of vertical transmission in women with COVID-19? So this has been really a point of interest for research studies. With vertical transmission, I think it's really important to all speak the same language, because at least in the initial data that came out, there was a little bit of inconsistency about what vertical transmission even really meant. So vertical transmission can be divided into essentially 3 categories. I mean, the umbrella here is mom is giving the infection to the baby, but that can happen either during the antenatal period, so sort of how we think of cytomegalovirus, with the potential to cause a birth defect, fetal demise. It can happen in the perinatal period, which would be at the time of delivery. And so the classic example of that is genital herpes, where the baby might be catching something sort of on the way out of the birth canal. And then the postnatal period, which is really mom just giving something to the baby through secretion, skin-to-skin contact, cough, things like that. And so really, I think the question that we're most interested in is whether there's antenatal vertical transmission, because clearly postnatal vertical transmission does happen. Perinatal probably could happen, but more through the same mechanisms as postnatal transmission. But is there actually transplacental transfer of the virus? And that's really been the point of a lot of research. If we look at, again, some of the initial data, there was evidence of placentas testing positive for SARS-CoV-2, even at the time of cesarean delivery, which suggested that there was some transplacental transfer, assuming that totally sterile technique was used to obtain that data. And since then, there's been evidence of SARS-CoV-2 being in several different kinds of obstetrical and fetal samples. And so this was a systemic review of almost 1,000 neonates born to mothers with COVID-19, of which only 3% of the babies actually had positive nasopharyngeal swabs, but there was evidence of the virus in cord blood and not very many samples, in the placenta and neonatal fetal and rectal samples, and there has been evidence of IgM and IgG antibodies in neonates. And so I think the research community does certainly agree that there probably is some vertical transmission, but if it is happening, it is not very common, and it is very, very, very rare. There have been some ultrasound findings even that have been transient in women with COVID-19, with body edema that has sort of resolved as the mom's illness resolved. Again, with these cases, it's just really, really hard to know whether it's the virus or whether it's coincidence, but I think we'll have more of that data hopefully again in the next couple months and years. So what practical considerations should be taken into account as specific to the management of COVID-19 in the pregnant patient? Well, in general, the oxygen saturation goal is a little bit higher. So we do want oxygen saturation to be around 95% in pregnant patients. It's a little bit lower in the non-pregnant population. We do know that pregnancy in and of itself increases the risk of VTE. And so we do use Lovenox or unfractionated heparin in these patients when they're hospitalized. Though the outpatient management is still unclear, it's really been individualized to the patient's specific risk factors. A lot of providers use D-dimer levels to kind of risk stratify and decide if a patient needs it, but we don't really have clear guidelines on this yet. Certainly in a patient who's, say, affected at 13 weeks, are they going to be on Lovenox for the whole pregnancy? Are they going to be on it for 2 weeks? So hopefully we'll have some more clear guidance on this soon. And then the type and frequency of fetal monitoring, timing of delivery, mode of delivery, all of this is really, really individualized. And this is not new to COVID-19. I mean, this even for severe early preeclampsia and things like that, there's not necessarily a rule that will apply to everyone. All of this is really nuanced, and we do have to take into consideration a patient's specific state and also the fetal well-being. And then a note on maternal positioning and proning. Proning, of course, has been used really commonly in the non-pregnant population as sort of a mainstay of treatment for patients in the hospital. Of course, there's always concern in doing this in pregnant patients. And so this is actually an area where I think that us as OBs and MFMs can be really helpful to our colleagues in medicine and the internal or the intensive care units, because we can sort of help providers feel a little bit more comfortable in putting patients in this position. Certainly, pregnant patients can be proned, but care has to be taken to sort of pad, of course, the gravid uterus. And there's also a modified prone position that's been described, or not completely on the belly, but a little bit sideways, just to be able to alleviate some of that respiratory stress. And then to closing here, talking about some of the pharmacologic treatment and the limited data among pregnant women. As we all know, pregnant women are generally not included in most of these trials. For remdesivir, which is a NIH-approved treatment for COVID-19, we were lucky to kind of contribute to some of the earlier data that came out in remdesivir in pregnant patients. And so this was just a case report, but we used remdesivir in conjunction with an IL-6 blocker, which is not used so much anymore. But we did find a decrease in inflammatory markers using remdesivir and an improvement in clinical symptoms using this drug. And that we're fortunate enough with one of my partners, Dr. Richard Berwick, to participate in this report of the compassionate use program of remdesivir, which was available to actually pregnant women and children during the initial part of the pandemic, and now is, of course, much more readily available. But we found that pregnant patients overall did do quite well with remdesivir, and there were really few adverse events related to the drug. Dexamethasone has been shown to decrease mortality with COVID-19 in at least patients who have severe disease. And so dexamethasone along with betamethasone are two steroids that we actually use really commonly in pregnancy for fetal lung maturity for patients who are at risk of delivering preterm. And so we also published a case report showing our experience using dexamethasone in a patient that actually did quite well with it. Was pretty much in the ICU and really on the verge of not doing so well. And as soon as we did give her dexamethasone, did improve. Whether that was a dexamethasone, whether that was going to happen anyways, of course, hard to tell from one case. But certainly we have been using it in conjunction with remdesivir for our luckily few cases that we've had to treat here at Cedars. It's been suggested, because dexamethasone does cross the placenta, to kind of use our standard dosing at fetal lung maturity dosing and then transitioning to a different steroid to complete the 10-day course and using a steroid that actually doesn't cross the placenta. And this hasn't been totally studied, but it's been recommended by our MFM experts. And then convalescent plasma was used actually, I think, more frequently earlier in the pandemic. There still are some ongoing clinical trials that are including pregnant women, and so it's still recommended if convalescent plasma is going to be used in pregnant women to do it through a clinical trial. And I believe that there's 2 studies, maybe at 10, that are including pregnant patients. So really outside of that, it hasn't necessarily been advised. And then the question has been on so many people's minds now that this data is starting to come out with the vaccines, is will pregnant patients be able to receive the vaccine, and what do we know about how these patients are going to do? And so, of course, and that must be maybe 2 weeks ago, or maybe a week ago, the interim analysis from Pfizer just came out from their vaccine, and they analyzed about 94 patients that were affected with COVID-19, of which the majority received placebo and not the actual vaccine. And they did a 1-to-1 randomization Their goal is to enroll 44,000 patients and then seek an EUA from the FDA hopefully later this month. I don't know how long that process is, and I don't think any of us know yet whether that EUA is going to include pregnant patients. Of course, our hope is that they would. However, of course, pregnant patients are not included or were not included in this trial, nor to my knowledge have they been included in any of the other vaccine trials that are taking place right now in the United States. Interestingly enough, Pfizer did expand their inclusion criteria to include children as young as age 12 in October. It was actually to age 16 prior to October. And so we had a faculty meeting last night, and we're talking about how a pregnant patient can actually consent for her child, but is not able to consent for herself to be enrolled in these trials. And then, of course, hot off the press, the Moderna vaccine just released their results yesterday or the day before, showing a 94.5% success rate of 95 affected patients in their interim analysis. 5 had received the vaccine and 90 had received placebo. And so these vaccines are similar. They're both mRNA-based viruses. For the spike protein, which is important in adherence to the ACE2 receptor. Pregnant patients were also not included in this trial, but they are apparently doing some safety studies in pregnant animals, and we don't know any of the results from that study quite yet. And so on the bottom here, I just kind of summarized these two, although there are several other companies that are also in phase 3 trials for the vaccine. It is a 2-dose vaccine timed about 3 to 4 weeks apart. Their storage is a little bit different for Pfizer and Moderna, but both of them have to be stored in cold environments. And interestingly enough, the pregnant patients were not included in either. Moderna actually even specifies that patients who are enrolled in their trial must also agree to be using contraception or abstinence while participating in the trial. So people are, of course, understandably not happy about this. And so many of our professional organizations have come out to say that this is really not okay, and pregnant and lactating women should be included not only in trials for the vaccine, but really for treatments for COVID-19. And so I don't think that I need to say these to this group here, but for completeness sake, I will go through them. Of course, results from studies are not always generalizable to the pregnant patients. There's a lot of physiologic changes in pregnancy that, especially for COVID, may be expose or predispose them to certain complications of respiratory illness, and to understand how these drugs are going to work in that specific patient population, we have to study these drugs in the specific population. And then, of course, fetal safety is most often cited as the reason to not include pregnant patients, but often unreasonably so. So even early on in the pandemic, when Plaquenil was being used really frequently, of course, we're not using that anymore. Even in those studies, pregnant women weren't included. And Plaquenil is something that we've been using for pregnant patients with lupus and other autoimmune disease for decades, but it has a ton of safety data. So even if that's cited as a reason, it's often unreasonable even to use that as an excuse. And then, pregnant patients do have rights to autonomy. They are able to make decisions for themselves. They are able to consent. And so this idea of pregnancy as a vulnerable population, certainly they are at a higher risk population for certain comorbidities, but I wouldn't say that they're vulnerable in terms of their decision-making capacity. And especially for a pandemic, pregnant patients are a member of the community. And so for striving to find a vaccine that will be able to vaccinate the majority of the members of the community, well, pregnant patients are part of that community. And so are we really doing the right thing by not offering the vaccine to a huge proportion of our patients? And so future directions and kind of ongoing studies at Cedars, I feel fortunate to be part of an institution where we actually do have a trial that is including pregnant women for treatment of COVID-19. And so this is, again, one of our MFM partners, Dr. Berwick, who is leading a study looking at complement blockade in patients that have COVID-19, and they are allowing pregnant and postpartum patients in this. The CORAL study is also at Cedars-Sinai, which is a longitudinal study of patients that are infected with COVID-19, and they're also including pregnant and postpartum patients in this study. The Priority Registry is a national registry. They recently published 2 papers summarizing their work, and it's mostly on how these women with COVID-19 with mild disease present. They've actually finished enrollment, but will be doing long-term follow-up on these patients. And so we're all looking forward to see how these patients do in the long term. And then the MFMU, through the NICHD, is planning on studying records of over 20,000 women to kind of better understand how the healthcare delivery system changes because of the pandemic has affected OB outcomes. And I was fortunate to get to do a much smaller scale version of this work here at Cedars with Naomi Green, and we looked at how our own sort of policy changes on the labor floor impacted labor and delivery outcomes. And we're fortunate to learn that our C-section rates weren't impacted, our induction rates didn't go up, and at least our short-term complication rates also did not go up. What we found was that in general, moms and babies were just discharged a little bit sooner. And so I'll end there. I'm really fortunate to work with a great division and MFM and the Department of OBGYN. All of us are, of course, very, very committed to taking care of these patients with COVID. We've been, again, really fortunate that we haven't had a huge number of patients with this, but with each patient, we're learning a little bit more, and really looking forward to seeing kind of the larger studies come out with their data so that we're better able to take care of these patients. So thank you so much.
Thank you so much, Dr. Naqvi, for such timely and important information. Really appreciate it. Our next presentation is going to be from Dr. Ravi Durjati, whose research is focused on understanding the relationship between the structure of the perinatal care delivery system and outcomes of care. He is particularly interested in interventions to improve to improve care and outcomes for vulnerable infants and mothers. His work at the Prophet Lab at Stanford University and the California Perinatal Quality of Care Collaborative, CPQCC, applies quality improvement science to address disparities in perinatal care. Through CPQCC, a data-driven statewide maternal and infant health quality improvement organization that provides collaborative improvement efforts to its nearly 140 NICUs and 250 maternal hospital members, he has a unique opportunity to work with a range of stakeholders to advance the health and well-being of mothers and infants throughout California. Thanks for being with us today, Doctor.
Thanks, Martha. It's a pleasure to be part of this gathering here today. A couple of minutes while I start to share my screen here. Okay, can everybody see my screen?
Yes, looks good.
Okay, thank you. It's a pleasure to be here and to talk about our work on improving care for vulnerable infants in the NICU. Let's start with the primary question. Are there disparities in perinatal care? I think the reason and the purpose we ask this primary question is because we want to try to understand what's the social context in which disparities in perinatal care emerge. So the ongoing pandemic, as Dr. Naqvi has alluded to, has really laid bare some of the stark fault lines that exist in our society related to race and class. And these fault lines have life and death consequences for minority populations. And when we think in terms of the fact that disparities in care do not emerge in isolation, the context in which care is delivered, the lives and societal conditions in which people live, work, have a very strong influence on disparities. And as a society, we are grappling with some of the most insidious forms of structural racism that disadvantages minority populations. And that is the background in which we are trying to understand the disparities that emerge in perinatal care. So let's think broadly about the origins of disparity. When we think in terms of disparity, we're thinking not just specific to the population of preterm infants, we're thinking not just in terms of genetic and epigenetic causes, which are very important, but we're also thinking in terms of the social determinants of health. And for a long time, we've believed that the care that we deliver in the NICU, high quality care that we deliver in the NICU, is a great equalizer when it comes to outcomes of preterm infants. But more and more we are learning that this is an assumption that needs to be challenged. My colleague, Dr. Sigurdsson, conducted this extensive systematic review where she has identified evidence to show that preterm infants who are cared for in the NICU receive differential care, and they receive differential care in terms of the structure of the care delivery process. For example, preterm infants from minority preterm infants receive care in NICUs which have high levels of nurse, low levels of nurse staffing. There are differences in terms of processes of care. For example, disparities related to referring to high-risk infant follow-up, disparities that are related to breast milk initiation and sustaining breast milk initiation in the NICU, and disparities related to outcomes. And it's the fundamental question that we are trying to answer is, what are the mechanisms for disparities in NICU care? And when it comes to disparities in NICU care, that really, when we think about this, there are two fundamental mechanisms. Minority mothers and neonates can have worse outcomes than whites because they receive care from facilities that treat patients with poor quality of care, which we call between NICU disparities, or they receive worse quality of care within a NICU. And there is evidence that's emerging that both these mechanisms are at play and they cause these disparities. So if we look at disparities between hospitals, what we can identify as institutional racism, work from the work Dr. Elizabeth Howell in New York has illustrated as in a very stark fashion that minority infants, minority preterm infants receive care in lower quality NICUs. The first thing is that the quality of NICUs here that have been studied varies quite widely, and minority infants receive care in lower quality NICUs. So when we think of disparities, we think of risk and we think in terms of quality of care. And this study is very important in that it gives us a sense that 40% of the Black-white disparity and 30% of the Hispanic-white disparity was explained by the birth hospital. That is where the preterm infant was cared for. Now we have studied this on a national scale, looking at data throughout the country from the Vermont-Oxford network, and we find that minority infants are cared for in a concentrated and different set of NICUs. So there is evidence that's emerging for segregation within the NICU. And here's an example. This is illustrated by a Lorentz curve for segregation that is shown here. If on the x-axis, you see the cumulative percentage of white infants, and on the y-axis, you see the cumulative percentage of non-white infants. If there was no segregation, then all these curves that identify Black, Hispanic, and Asian infants should be along the diagonal. But the very fact that they're not, that they're away from the diagonal illustrates that there is segregation of minority infants into specific NICUs. Well, if there's segregation, then what about the care that is received by minority infants in these institutions? And this study in California that we conducted showed that Blacks were more likely to be cared, Black infants were more likely to be cared in hospitals with higher health care associated infection rates, and that Hispanics infants were more likely to have a healthcare associated infection. So we've talked about disparities that exist between hospitals. Now there are disparities within hospitals also, and we see evidence for disparities between and within hospitals in specific outcomes of care as well. When we consider NEC, when we consider breast milk at discharge, we find that there are these disparities that exist. When you think about disparities within hospitals, we can think about, are there disparities in specific clinical processes of care? For example, let's take the example of access to kangaroo care. And this study demonstrates that when we ask parents about the help that they receive from the NICU in initiating kangaroo care, there were differences by race and ethnicity, differences that shouldn't ideally exist, but the fact that these differences exist is a cause for concern, especially on modifiable measures of quality like access to kangaroo care. But then we are, as a community, we have this sense, or we have this assumption that we treat all patients the same, right? So this is another assumption that seems to be challenged by the evidence that is coming through. And this is a lovely study, a qualitative research of the types of disparate care that are seen in NICU. This is again comes out from our lab. And we identified 4 different types of disparate care. The first 3 are suboptimal care, and suboptimal care that is that reflects neglectful care in the NICU, judgmental care in the NICU, and systematic barriers to care. And on the other end of the spectrum, there were families who had social, economic, or racial privilege, and they tended to receive priority treatment. And this is again work, qualitative research that's led by my colleague Krista Sigurdsson. And one of the things that came up as part of this work is also that the fact that language barriers are a major reason for disparities, and therefore an opportunity for improvement as well. If we look at the types of disparate care, the stories that families have told us, for example, if you think in terms of neglectful care, so here is an illustration of neglectful care. A family in the NICU that was from the Middle East, there was a language barrier. The dad was very demanding, and somehow the sort of interactions that the NICU staff had with the family ended up being that they widened the gap for care for this family. And these interactions resulted in what could only be called neglectful care. Here's an example of judgmental care. So here is a family that's in a relatively rural area, mostly white, and the NICU staff had some judgments about the family, and what did those judgments end up doing, right? The judgments ended up preventing the mother from participating in the care of the infant. Some nurses would not allow the mother to even hold the infant, and therefore there's this idea of personal biases that became very apparent. There are also systematic barriers to care. This is an example of a Hispanic infant, and the parents didn't have transportation and they had irregular working conditions, and in this case, poverty resulted and difficult working conditions resulted really in an unfortunate outcome in which the child protective services were called. And again, an illustration of the systematic barriers to care that vulnerable minority families face. So when we relate these stories that families have told us, we should always remember that these stories really are telling us about disparate care for families and not strictly for infants. I have given you a sense that there are these 2 forms of mechanisms of disparate care, one that is related to quality differentials between NICUs and and the second one, which is related to quality differences within a NICU. We want to talk as a community about solutions, and so I'll spend the next 5 minutes talking about solutions that we are trying to advance the field with. When it comes to improving quality of care, measurement has always been the first step to improvement, and we at the CPQCC have been in the forefront of efforts to measure the differences in quality of care, we have developed a health equity dashboard that all 140 member NICUs within California who are part of this network can access. The dashboard gives them a very clear sense of where problems are in their NICU with regard to specific outcomes of care as well as processes of care. We're also in the process of developing and implementing measures of family-centered care. We recognize that to address these disparities, we need to have really strong provider-family partnerships, and we have developed point-of-care derived measures in collaboration with disadvantaged families, and these measures were selected with a national expert panel, and we are looking at implementing these measures so that it advances a range of desirable outcomes for families. There's also ongoing work about disparity reduction through technical quality improvement. There's been multiple thoughts in the research and in literature about whether what form should quality improvement take in order to reduce disparities. And we have some evidence that technical quality improvement can reduce disparities. In this particular example that we're sharing here, it's disparities in severe maternal morbidity that was reduced as a result of an 18-month quality collaborative that involved multiple hospitals coming together and working on this problem. So there is evidence to suggest that disparity reduction is possible through technical quality improvement. Changing what we do in the NICU. One of the themes for this conversation has been that what can we do in the NICU to reduce these disparities? And we have identified some thoughts that we would like to share and get some feedback to. And these solutions have been put together in 4 specific domains. We have a readiness domain that talks about how can an institute be ready to serve diverse populations? What can be done at the institutional level? It could be something as simple as in our NICU, you're welcomed as a partner in your child's care at all times. Recognizing the needs of minority families. This could mean counseling that's available for them, standardized assessment of social determinants of health, support for transportation, parking, food, childcare for siblings. The response domain is related to cultural sensitivity and language assistance. Language assistance really comes up as a critical need for solutions. Family-centered care is another response domain. Solutions related to improving family-centered care and putting together language concordance when it comes to caring for families. There are also hospital-facing solutions that may be related to structural solutions like having a family advisory council in the hospital, patient-facing solutions like peer-to-peer support programs, family-centered interaction with babies, and if family is not able to be present in the NICU, there's a potential for using technology and video and phone interactions so that the families can be part of the care that is being given in the NICU. And as a systems learning process, we are a quality improvement organization, and we've always used audit and feedback of quality measures by race and ethnicity. And these have been very helpful in improving quality of care. And we think that by using them and stratifying them by race and ethnicity, we will be able to drive improvement. I also want to draw the attention of the community to this wonderful paper, The Color of Health, how racism, segregation, and inequality affects the health and well-being of preterm infants and their families, by our colleagues from the Vermont Oxford Network. And they identify range of more than 50 potentially better practices that can be implemented in the NICU. And these potentially better practices relate to these 4 specific areas: identifying and mitigating social risks, recognizing that our responsibility does not end with NICU discharge, so partnering with community partners to help families, to develop quality improvement efforts to ensure equitable NICU care, and also to advocate as providers to advocate for social justice at the local, state, and national level. You have seen this slide before, and this slide was initially was shown to illustrate the mechanisms of disparity. So it's appropriate that as we come to the end, this slide also gives us a sense of where are the potential possible leverage points for action. So you can think of in terms of hospitals and health systems working with communities. You can think in terms of OB efforts to develop better prenatal care and efforts related to improving quality between and within NICUs, as well as transition to home. To summarize, we don't practice in a social cocoon. NICU care, unfortunately, there are disparities in NICU care that exist both within and between NICUs, and we need to prioritize these disparities and prioritize eliminating these disparities. Routinely measuring processes and outcomes by race and ethnicity and developing targeted QI programs will help. We think that disparity efforts should be incorporated into all QI efforts. Engaging family advisors is a simple thing that can be implemented in all NICUs. And more than just engaging family advisors, it's really about talking to families and trying to understand their needs. That's really important. And this is something that we urge everyone in the community to think about, to talk with your colleagues and try to implement some of the many solutions that we have thought about and others have also shared. So with that, I'll end the presentation and
Thank you so much, Dr. Durjati. What a great model you've held up and call to action for all of those who are caring for our tiniest little people in the NICU environment. Really appreciate it. So we are now to our last panelist, and I am happy to introduce to you Dr. Karen A. Scott. She is an associate professor with a joint appointment in obstetrics, gynecology, and reproductive sciences, and humanities and social sciences at UCSF. She is a sexual, reproductive, and perinatal epidemiologist and obstetric hospitalist whose program of research, interprofessional education, clinical practice, and policy are grounded in reproductive justice, Black feminism, research justice, and cultural rigor. Currently, she is the principal investigator of the Sacred Birth Study designed to examine safety, autonomy, communication, racism, empathy, and dignity in hospital births and validate a participatory patient-reported experience measure of obstetric racism, also known as the Prem-OB scale. Thank you for joining us today, Dr. Scott.
Hi, good afternoon, everyone. Thank you, Mashariki, Marta, Marcha Dimes leadership staff, and for organizing this event and supporting all of us in preparation for this day. Thank you to the panelists. Today I will present how I advance an anti-racist praxis in perinatal and reproductive population health research. Next slide, please. You've already seen my disclosures. Next slide. I'd like to introduce myself to kind of establish my positionality. I am a Southern born and raised Black woman from East Nashville, Tennessee, before gentrification. I'm grateful for the gift of a liberal arts education from the 5th grade all the way up until completing medical school. Therefore, I am a lifelong learner. I do believe this is the way. I also identify as a reproductive justice avenger, Wakanda healer, Yoda follower, and Care Bear hugger. I am celebrating my 18th year anniversary as a community-based trained and serving OBGYN. I also identify very strongly as a disruptive and transformative board-certified OBGYN, hospitalist, and epidemiologist, as well as a health crit. And my purpose is to advance Black feminism, cultural rigor, reproductive justice, and research justice and participatory quality improvement science, practice, research, and interprofessional education and training. Next, please. So at the end of this presentation, I hope that you'll be able to describe the race consciousness four-phase framework of public health critical race praxis, or PHCR, applied the PHCR praxis to perinatal population health equity research, and examine the social and clinical phenomenon of excess preterm birth and early preterm birth among US-born Black women with gestational diabetes using race consciousness. Next. This is still the year of 2020, the year of the nurse and the midwife. So much RJ love, adoration, joy to my sisters, famous people, and warriors. Next. So let's begin with the population-based retrospective cohort study that examines the association between preterm birth and nativity among Black women with GDM, published October the 6th, 2020 with my co-authors, mentors, and collaborators from the UCSF Preterm Birth Initiative. So what do we know? We know that GDM and preterm birth disproportionately develop in the pregnancies of Black women and significantly contributes to both perinatal mortality and morbidity. As an OBGYN, specifically an OB hospitalist and perinatal epidemiologist, I found that preterm birth outcomes in pregnancies affected by GDM remain unexplained in published literature, particularly among Black women and people. Clinically, we tend to focus on risk reduction in the areas of hyperglycemia, macrosomia, cesarean birth, and preeclampsia, but not specifically preterm birth within this particular population. So we know two things. The differentiating factor between the risk of preterm birth and GDM among Black women is maternal country of origin or nativity. Foreign-born Black women are less likely than US-born Black women to experience preterm birth, although foreign-born Black women may be more likely to develop GDM. Existing evidence explains the protective effect of foreign birth outside of the US through the healthy migrant theory, which describes how foreign-born persons who migrate to the US have significantly better health outcomes in comparison to US-born persons with the same racial and ethnic identities. In our paper, I assert that nativity, particularly among US-born Black women, may be a proxy for the impact of structural oppressions and life course experiences of over-chronic exposure to gendered racism, obstetric racism, classism, and other forms of discrimination and oppression unique to Black women. Next. Traditional big data epidemiological studies that rely on administrative databases tend not to contain structural and neighborhood factors to allow for temporal or spatial contextualization of the data beyond individual behavior or characteristics. Here I share an illustration published in our 2019 publication with nurse scientist Drs. McLemore and Britton, the ethics of perinatal care for Black women, dismantling structural racism and mother blame narratives. The image was adapted with permission from the Preterm Birth Initiative, the San Francisco Department of Public Health, and the CDC, describing the relationship between social determinants of health, structural determinants of health, health disparities, and health inequities across the reproductive life cycle. Next. In our analysis, we beautifully describe the relationship between the inequitable distribution of chronic illness and pregnancy conditions and the reproductive and general health of Black women and people with capacity for reproduction and our children across the life course. We also explicate the relationship between mother blame, defined as holding pregnant women and people exclusively responsible for the ill health of their children, specifically mother blame narratives, and misdirected and failed efforts to address structural inequities and incompetence through individual level interventions, AKA traditional medicine healthcare. And I quote, exclusively addressing individual behaviors as the basis for health outcomes without a structural perspective can lead to stigmatization, scapegoating, heightened surveillance, and criminalization, all of which disregard bodily autonomy of pregnant women and people. We also interrogate the investigators in fields of study such as the developmental origins of health and disease, public health, epidemiology, all who continue to contribute to reproducing mother blame and structural racism by viewing and treating the pregnant body as a vessel or incubator, requiring control, surveillance, and regulation, again, reminiscent of US chattel slavery, when the business of birthing enslaved Black people sustained the US economy and workforce. I added this 2013 image on your right by editorial cartoonist Nick Anderson to demonstrate the hypocrisy embedded in policies and service provisions that prioritize and protect the fetus during pregnancy and then criminalize, pathologize, and undermine parental attachment and autonomy. Next. To date, there are limited data that describe the association of nativity and preterm birth by severity, defined as early as 34 weeks, versus late defined as early preterm birth, less than 34 weeks, or late preterm birth, defined as 34 to 36 weeks, and subtype, defined as indicated preterm birth and spontaneous preterm labor, and early term birth, defined as 37 to 38 weeks and 6 days, respectively, in a high-risk population of Black women with GDM in California. To address this gap, we examined the risk of early preterm birth, late preterm birth, and early term birth by nativity among Black women with GDM. Next. We propose the application of an anti-racist praxis as a methodology to interrogate the racialized social and clinical phenomenon of preterm birth among Black women with GDM in California in quantitative population health research. In 2020, I needed to hold my research accountable to my own ethics of perinatal care, published in 2019. I needed my research to avoid the reproduction of mother blame narratives and structural racism in our assumptions and approaches to both understanding and describing individual level factors associated with differences in preterm birth among Black women whose pregnancies are affected by GDM and other clinical events. I also wanted to design a study that moved beyond describing health inequities and disparities to offering multi-level solutions to disrupt and transform healthcare service provision and research. My intentions and desired impact aligned with Drs. Ford and Erhi-Himbua, who in 2010 published the Public Health Critical Race Methodology in Social Science and Medicine to maintain, and I quote, maintain public health's highest standards for scientific rigor while drawing on the robust body of anti-racism work that exists outside of public health in critical race theory, or CRT. First, a study that involves Black and brown scholars or racialized exposures, populations, or outcomes does not automatically make the study a CRT endeavor. This is similar to folks who operate in reproductive health or rights, thinking their work is automatically grounded in the tenets of reproductive justice. According to the authors, both CRT and PHCR attempt to move us beyond merely describing and documenting inequities like water is wet toward understanding and challenging the power hierarchies that undergird them. Thus, PHCR helps public health researchers to carry out health equity research with fidelity to CRT. And on the slide, I adopted the author's PHCR schematic and followed the process outlined in the paper. The scholar must first establish a personally race consciousness orientation to the proposed work, clarifying how and why race consciousness orientation impacts the work. Focus 1 requires the scholar to describe key characteristics of societal racialization for the study time period, describing the racial hierarchy of groups to be examined. And we move on to Focus 2, where we identify, own, and describe the relationship between our disciplinary norms, narratives, biases, and proposed work. We must name the areas of alignment, conflict, and limitation that inform our path towards equity. Focus 3, we determine how to best operationalize these issues and implications we discussed in Focus 2. What traditional novel measures exist that allow us to adequately capture the racial equity concepts of our work? And this entire process brings us to Focus 4, and I quote, use the knowledge gained from the research to determine whether any action or actions can be taken to help counter the inequities under consideration and share study results, including its limitations and strengths with the affected communities. Next. First, I use a race consciousness frame. I believe structural racism creates a hierarchy of power, domination, privilege in society that impacts the distribution and expression of illness and health, as well as access to and utilization of resources to meet and maintain basic needs, such as water, housing, food, family, community, and stability, employment, and safety. And number 2, I believe the structural context of living as a Black woman in the United States impacts perinatal and reproductive health and healthcare outcomes and experiences in a manner not reported nor described in white women or foreign-born Black women. I know this as a Black woman, as both a patient, physician, scientist, activist, daughter, sister, friend, and more. Next. We continue through this process. So focus number 1, contemporary patterns of racial relations. We situate the racialized clinical and social phenomenon of preterm birth in the United States within a temporal and spatial context, underscoring the ongoing threats to achieving and advancing perinatal and reproductive health equity based on 4 trends eloquently described by a Black OBGYN, a Black Brown OBGYN physician scientist, public scholar, and myself in our 2020 publication. And these trends include the feminization of the OBGYN workforce without a concomitant, equitable, racial, ethnic diversification of the workforce, geographic maldistribution of the workforce and services in rural areas, urban areas, and areas adjacent to urban centers, absence of any OBGYN physicians in nearly half of US counties due to the shortage or absence of a hospital with obstetric care and or an obstetric provider, i.e. maternal care deserts. And 4, lack of racial concordance between the workforce and the public, particularly in rural areas and urban areas, in areas adjacent to urban centers, and particularly in the Midwest and southern regions, and I would also say in some areas in California. We move to focus 2, knowledge production. We interrogate existing evidence that perpetuates a racist narrative and norm where perinatal and reproductive health professionals approach Blackness, Black bodies, Black existence, and Black births as intrinsic biological defects. Quantitative population, perinatal, and reproductive health research of preterm birth by Black women scholars provides substantial evidence with both scientific and cultural rigor on the utility of correlating adverse outcomes among Black birthing communities with traditional and novel measures of structural racism, such as neighborhood level segregation and census tract data, and county level disparities in incarceration and elected officials. Focus 3, the conceptualization and measurement. The exclusion of white women as a control group for all 3 gestational groups, early, late preterm birth, and early term birth, allows for better examination of within-group variations among Black women birthing in California hospitals based on nativity and other clinical factors without reinforcing race as a biological construct or advantage in examining the racialized phenomenon of pregnancy, GDM, and preterm birth among Black women. Likewise, we operationalize intersectionality through the utilization of interaction analyses and backward stepwise regression modeling. And then we move on to focus 4, action. We use knowledge generated from our study to disrupt the reliance of clinical outcomes as defined in administrative databases as the predominant approach to examining the causes of preterm birth inequities. Instead, we propose the use of a patient-reported outcome or experience measure of preterm birth among Black women and birthing people with GDM in clinical settings, particularly when clinical significance outweighs statistical significance. Next. So this study is a retrospective cohort study using linked birth certificate data and hospital discharge data for about 2 million women. After we went through all the various selection processes, we ended up with 8,609 non-Hispanic Black women with GDM in the study who gave birth between 2013 to 2017. Next. Our outcome variables were organized into 4 gestational groups: early preterm birth, late preterm birth, early term birth, and term birth, inclusive of both full term, late term, and post term. Next, please. This diagram describes the outcome variables in a different manner to differentiate between preterm birth subtype and severity. There were 3 types of preterm birth that were assessed: preterm premature rupture of membranes, or PROM, spontaneous labor with intact membranes, and also provider-initiated preterm birth, maternal, placenta, or fetal indications. And preterm birth, again, severity was categorized as either early or late. Next slide. So these are the predictive variables that were described. Again, they were self-defined. Our predictive variable was maternal country of origin. We also had a list of control variables that you see representing maternal, obstetric, and social characteristics. Next. We conducted various types of statistical analyses and modeling in order to get the adjusted odds ratio, as well as the confidence intervals, again, to calculate a relative risk of preterm birth by severity and subtype, as well as early term birth using multivariate regression modeling. Next. Some of the demographics of the study participants are shown here on the slide. It is long. Our paper is open access, so you can review them. And I just wanted to briefly share that the things that are highlighted in colors just relate back to the differences between US-born and foreign-born folks. So approximately 83% of Black women with GDM were US-born and 16.1% were foreign-born. The overall prevalence of early preterm birth and late preterm birth and early term birth was 3.8, 9.5, and 29.9% respectively. Compared to foreign-born, US-born Black women in California with GDM were significantly more likely to give birth under the age of 25, to experience a prior preterm birth, to obtain 12 years or fewer years of formal education, to develop preeclampsia at birth, and to smoke in pregnancy next. Again, similarly, US-born Black women in California with GDM were significantly more likely to rely on public insurance, to experience pre-pregnancy obesity across all three classifications, and interestingly enough, to achieve adequate or adequate plus prenatal care utilization despite all of the other adverse outcomes. Next slide. The prevalence of preterm birth, including subtypes, spontaneous and indicated preterm birth among all Black women with GDM was 13.3%, shown here in table 4 on your left. Overall, 14%, about 14.2% of US-born Black women with GDM had a preterm birth compared to 8.9% among foreign-born Black women. Our study findings revealed significant differences in the proportion of total preterm birth by maternal country of origin, with the largest contribution towards preterm birth found among foreign Black women in California from Ghana. And table 5 on your right shows no difference in prevalence of preterm birth by subtype by maternal country of origin in our sample population. And next slide, for the sake of time, I'm going to get you down to our final model so that you can see that we found that foreign-born status is associated with decreased odds of preterm birth, irrespective of severity and subtype, based on these adjusted odds ratios. Foreign-born status had no differentiating impact on preterm birth severity among Black women with GDM, given the similar adjusted odds ratios that were overlapping between early and late preterm birth. Similarly, foreign-born status had no differentiating impact between preterm birth and early term birth. The second row and the slide shows the variables and the interaction terms that remained in the final model. These are areas of overlap across, there are areas of overlap across all three outcomes, such as prior preterm birth, preeclampsia, and obesity. There are also differences in predictors of early births, less than 39 weeks across all three outcome groups. Next slide. So our data demonstrates excess preterm birth among US-born Black women with GDM and suggests preterm birth among multiparous Black women with GDM in California may not be a transmittable genetic defect obligating US-born Black women and their children to a lifetime of reproducing harm as a result of birthing while Black. Thus, social and epidemiological studies can be strengthened with the reporting of patient measures defined and developed for and by Black birthing communities so that clinicians of Black birthing communities can make evidence-informed decisions together to improve patient-centered and focused care. Preeclampsia was the overall greatest predictor across all three groups after a history of prior preterm birth. The largest effect of preeclampsia, given no evidence of interaction between nativity and preeclampsia, suggests a potential role for unmeasured independent variables such as stress, inflammation, or chronic hypertension as potential pathways for preterm birth among Black women with GDM. Likewise, GDM and preeclampsia may also act synergistically through a common pathway of inflammation, whereby preterm birth may actually be the manifestation of vascular dysfunction, given the significant associations found between preeclampsia, smoking, and preterm birth. The presence of interactions between smoking and obesity in the final models for early and late preterm birth also suggests a shared pathophysiological mechanism, again leading to this inflammation and vasoconstriction among Black women with GDM, resulting again in this phenomenon of excess births prior to 37 weeks. Next slide. There are two key clinical implications of our study. And for the sake of time, I want to focus on one. Let's reimagine the provider-initiated induction and care for preeclampsia among Black women whose pregnancies are affected by preterm birth, GDM, and obesity. Provider-initiated births likely resulted in prolonged use of oxytocin for induction and augmentation of labor, as well as prolonged exposure to magnesium sulfate for the purpose of seizure prophylaxis or fetal neuroprotection. A sub-analysis in our study of birth types by gestational groups showed that among 8,604 Black women with gestational diabetes in California from 2015 to 2017 revealed high hospital performance of cesarean births among 3 out of 4 Black women who experienced an early preterm birth, and nearly every 2 out of 3 Black women who experienced a late preterm birth underwent a cesarean birth. Given the most predictors of preterm birth among Black women with GDM, regardless of preterm birth severity or preeclampsia, smoking, and class 2 obesity within the context of provider-initiated births as a result of preeclampsia, and the high hospital performance of early preterm and late preterm cesarean births, our data raises concerns for the increased burden of postpartum hemorrhage and its social and clinical sequelae among Black women with GDM in California who experience preterm birth. Next slide. I'm very proud of the work that we accomplished. Each strength adds to both the cultural and scientific rigor of the study. I am most proud of explicitly acknowledging and utilizing an anti-racist praxis to inform our ethical, methodological, and theoretical approaches. Two key limitations did trouble me as an OB hospitalist and applied epidemiologist is the lack of indications for provider-initiated early term birth, and lack of information about the clinical and community experience of seeking care as a Black woman with GDM based on nativity. Next slide. So in our conclusions, we know that foreign-born status remains protective of preterm birth irrespective of severity and subtype. Preeclampsia, preterm birth, and GDM share pathophysiological mechanisms, suggesting a need to better understand differences in perinatal stress, chronic disease, and vascular dysfunction based on nativity and future epidemiological studies and health services research. Our study increased our curiosity and resolve to examine differences in social capital and kinship, as well as glycemic control based on nativity, as well as examining differences when community-informed, midwifery-led, racially concurrent group prenatal and postpartum care with wraparound services with doula support, how that can also impact the outcomes and the experiences. And thank you. Next slide. Thank you so very much. You can follow us on social media.
Thank you so much, Dr. Scott. That was incredible and gave me, and I'm sure everyone on the webinar, so much to think about. It's really wonderful. Thanks so much. So we are just a few minutes shy of our closing time at 1:30. If you have a question and haven't chatted it in, feel free to do so very quickly. Mashariki, is there one or two that have already come in that you want to elevate?
Well, everything has been answered by the physician already, the panelists already.
Wonderful. All right. Well, then I'll take this opportunity to thank all of our panelists again for sharing their expertise, and even more importantly, to thank you for the work you do every day to improve the health of moms and babies. We really can't thank you enough. So for all the attendees, you will receive an email shortly with the March of Dimes Prematurity report card, a link to our evaluation, and information on how to receive continuing education units should you care to pursue that. Mashriki is also going to maybe pop the evaluation link in the chat, because we really do appreciate your feedback about this webinar and thoughts about potentially future webinars. So we hope. Go ahead.
Oops, sorry. I do have one question, actually. And that is for Dr. Scott. Looking at your sort of the community and clinical implications of the research and outcomes, how can there be a link between community and the clinical setting? And you think of, programs like WIC, programs like Black Infant Health, community-based organizations, how can they partner with clinicians and the hospital medical space to improve outcomes and kind of advance the work that you're doing?
Thank you, Mashariki. So it goes into like our final conclusion was, our recommendations are basically showing that when we look at the data around the burden of excess burden of preterm birth, particularly amongst Black women with GDM, and all of the requirements in terms of the increased surveillance, increased visits, even during the pandemic where we aren't able to maintain, some systems are not able to maintain that because of socially distanced measures. I think it's very crucial to really be tapping into community supports and services such as doula, such as Black Infant Health, such as lactation consultants. It's clear that with the increased association of inflammation, vasoconstriction, all those things being associated with hypertensive or vascular disease and stress, and also racism. How do we provide the additional support that historically in our country really has undermined social capital, social networks, kinship among US born Black people. And so that is what I'm beginning to wanting to study, which we're doing with Sacred Birth, is like, how do Black mothers and birthing people utilize social capital and kinship to insulate themselves from essentially the terrors and the horrors of engaging a healthcare system. And when the pandemic hospital-based policies restrict people to one, and someone has to choose between a partner or a healthcare professional, which is still unethical, but may be necessary, we still need to acknowledge that the impact of how social capital and kinship protects, and then we take that away, which we could exacerbate. So I think this is just evidence to prove that there are certain models of care that work really well for decreasing preterm birth, low birth rate, NICU admissions. It's not one-to-one traditional care. There's evidence that shows group prenatal care does that. Nurse home visits do that. So I think that healthcare physician-driven models of care and leadership need to acknowledge that actually interactions with us, and I am a physician, does not move the needle for Black people particularly. There is data that says that. So I think we should, if we're data driven, then we need to support group prenatal care. We need to support nurse home visits. We need to support lactation consultants. We need to support mental health because the data keeps showing that's what structurally marginalized and minoritized communities benefit from, that we need to make those transformations in healthcare systems.
Thank you so much.
Yeah.
All right. Well, sadly, we are now at 1:30. So again, thank you, panelists. Thank you for our attendees. We hope some of you will join us tomorrow as we'll have our second webinar at the same time. The registration link is the same one that you used for this one. So be in touch if you need that information. And again, thanks also very much. Have a great rest of your day.